right now. Okay, thank you, Joao. I'm very grateful for your presence here. I will introduce yourself. I think you don't need any introduction as well. But anyway, um, I'm really happy you're here. I was a long time no see, and I hope we can see in the near future. Probably we'll meet in Kyoto. I really am looking forward to it, and I learned so much from you. The time I spent in Fortaleza with you, and the times you came here to Barcelona to teach us everything that we can do now. And again, I'm very grateful for you to explain to us a lot of things that I've learned from you, and endoscopic ear surgery principles and tips and pearls and whatever you want to tell us. That's great.
So thank you, Ricardo. Uh, it was very nice when you came here to Fortaleza, and it's a great pleasure and honor to me to talk to you and to your friends about this subject that I like very much, which is endoscopic ear surgery. And when you asked for a topic, I decided to talk about the principles because I really believe it's if we understand the physiology, the anatomy, we can do whatever you want, or endoscopic or microscopic, but as long as you respect first the anatomy and second the physiology. Doing this, respecting the anatomy and physiology, probably you will have good and excellent results on your cases and benefiting your patients, which is the most important. So we are going to talk. This is a QR code. If you put like your cell phone against the QR code, you're going to be redirected to the YouTube channel that probably some of you know, and all the videos of these presentations are there, including the historical videos. So you can download the historical videos and then you can put on your presentations. So I think it's nice. And talking about history, this is an historical movie about a mastoidectomy done without a microscope or without drills, without endoscopes, without fancy instruments or coblation or cautery, just with a chisel and hammer in order to open the mastoid, in order to remove the disease. Hearing was not an objective. You would expose the mastoid bone. All the surgeries were canal down at the time, of course, and no microscopes were used. As a matter of fact, if you used a microscope, you would be considered to be like blind or something like that. So it was very interesting to see this movie because during the COVID pandemic, I had to do some cases of automastoiditis, and we could not use the drills because we were all afraid of the aerosolization of the virus. So since I had those movies, I decided to do the mastoidectomy with a chisel and a hammer, and it was very interesting. Not that I recommend to do the surgery like this, but it was very interesting, and we could do the procedure without the drills. So this is just an example for you to see how we can understand the anatomy and how can we do the surgery without the instruments that we do today. Because I like to show these movies because sometimes, especially when I talk to the residents and to the young people, they think that we do this thing that we do since the caves, since like Hippocrates. But it's not. Medicine is an evolution. As a matter of fact, medicine is the science of the transient truth. What is true today can be a lie tomorrow, and what is a lie today can be true tomorrow. So we saw this in COVID times. And this is another surgery of Dr. Lampert. Lampert performing a fenestration. The fenestration was a surgery that made Dr. Lampert very famous in the world, and was a surgery for autosclerosis. So of course, no one does fenestration anymore because the long-term results are not good for this operation. But this made Dr. Lampert very famous and very important, and considered by some the father of modern otology. He never used a microscope. He was one of the first ones to use a drill, a modification of a dentist drill. Because of that, he was expelled, kicked out from his hospital, from the hospital that he would operate. So he is using like the dentist drill here and no microscopes, just like a magnification loop, and no microscope. As a matter of fact, he had on his office, his office was in Fifth Avenue in New York City. So he had like a board, and was written like this: if you operate the ears, and if you use a microscope to operate the ears, probably you are blind. So that's what Dr. Lampert thought about the microscope at the time. And the last historical movie I'm going to show is this movie from Dr. John Shee. Dr. John Shee is considered by many the father of sclerosis, modern surgery, of stapedectomy. So he was one of the first ones in America to use the microscope to operate the ears. Because of that, he was completely marginalized, like he was put aside between his peers because he was using a microscope, and it was like a kind of a sacrilege to use a microscope at the time, because the image quality was not so good at the time. If you think about the image quality that we have today with modern microscopes and modern endoscopes, the image quality, including the quality of the image capturing devices, were not so good at the time. So he was doing a staph surgery at the time with a microscope, and he was one of the first in America to use a microscope. And because of that, he changed the way we think and the way we understand the anatomy and the way we operate the ears. The same thing, I would say, evolution, or the same history took place at rhinology, because we came from microscopes to we came from eyes to magnification loops to microscopes to endoscopes to combined approaches. I saw many cases of combined approaches with my teacher. He would do the surgery with a microscope to do like ethmoid and sphenoid sinus, which is very nice because it's straight, so you can have the second hand as a suction. And the maxillary sinus and the frontal sinus he would do with the endoscope because it was easier to perform with the endoscope. So these were in the 2000s, so 20 years ago, not many years ago. And nowadays, everyone does endoscopic sinus surgery. And at that time, I mean, not in the 90s, but in the 80s or even in the 70s and in the 60s, people were allowed to drink and to smoke in OR. So this is a general surgery. And just to demonstrate that people could smoke at the OR, and because of the use of cigarettes in the OR, that's the legend, I say, but I think it was true. Professor Messe Klinger was doing an endoscopic sinus surgery in Austria at the time. And all the surgeries at the time were under local anesthesia. He would sit down near the patient, put the endoscope, and do the surgery under local anesthesia. And he was smoking at the time because you were allowed to smoke as a surgeon, like this surgeon is smoking at this time. And then he was with the endoscope inside the nose of the patient, and pieces of ashes of the smoke of the cigarette ashes went into the nose of the patient, and he, with the endoscope, which magnifies the image, he saw these pieces of ashes moving inside the nose. He asked the patient not to breathe at the time because he thought it was because of the air movement of the breathing of the patient, but he still saw the movement of these ashes. So he went on to study the mucosa of the paranasal sinus and the nasal cavity, and he discovered the mucociliary clearance. So that's very interesting. And because of the endoscope, because of the use of endoscopes in the ear, we also can understand that the ear mucosa and the mastoid mucosa has also mucociliary clearance. We can see the red blood cells, as you can see here, but also we can see mucociliary clearance, as we see here. This is the promontory. This is methylene blue that I put, and this is 8 times the speed, the normal speed. But you can see that the mucociliary clearance goes towards the protympanic space and the eustachian tube. So the mucosa of the middle ear, the mucosa of the mastoid, has a function. If we destroy this mucosa, maybe we are destroying this function. That can be useful for us at the postoperative period, at the recovery period for the patient. So this is important to understand that mucosa of the middle ear and mastoid mucosa, they have a function. They are functional mucosa. So that lies on the principles of endoscopic ear surgery, but I mean the principles of ear surgery. What should be the principles of ear surgery? You should fix the problem and trying to do less harm possible for the patient. when I say less harm is trying to preserve the hearing whenever it is possible, trying not to have a facial problem, a facial nerve problem, trying not to have reinfections. So we have to fix the problem, but trying to be as conservative as we can sometimes in order to preserve as much as we can the anatomy and preserve the physiology that is present at the middle ear mucosa. So if we understand the animals that have middle ear, we go back to the evolution, if we believe in the evolution theory, and we think that fish and amphibians, they don't have middle ear. They don't need to have middle ear, and they don't have mastoid. Why? Because the sound is an energy. When you have this energy that is transmitted from one kind of mean, water, into the same kind of mean, same water, because in the cochlea there is endolymph and perilymph, which is water, you do not lose energy. So the energy the sound energy that is broadcast into the water, fish live into water, amphibians live into water, is not lost because of the change of means, because in the cochlea, still water. But when we gain earth, reptiles, birds, and mammals, we needed a device in order to amplify the sound in order for us to hear, because inside the cochlea, still water, perilymph and endolymph, but outside now air. So this sound energy would not be transmitted in the water anymore, another mean. So we would lose energy whenever we converted it into the water inside the cochlea, and then we would not hear very well. So evolution created a way, a mechanism to amplify the sound. So the middle ear, what's the function? Why do we have middle ear? Number one, to amplify the sound. This is the answer of the middle ear. And these bones, they came from the bones that we used to chew, the mandible, or whatever, blah, blah, blah. But this is not important. The important thing is we amplify the sound. To amplify the sound, we have to have air inside the middle ear. If we do not have air, the sound is not amplified. We see this in otitis serosa's patient that has liquid inside the ear, that they have a conductive ear problem. So the second question I always ask during the lectures is, where does the air come from? And then people say, okay, it comes from the nose. I say, it's not entirely true, this answer. Yes, it comes sometimes from the nose, but most of the air comes from the mastoid. The reason that we have the mastoid is that the mastoid has the same embryological origins of the alveoli of the lungs, and they can have gas exchange properties, the mucosa. That's why we have a lot of cells in the mastoid to have a big surface to have this air production, this gas production, as a matter of fact. And what gas is produced? It's not oxygen, it's not another gas, it's nitrogen. And look, nitrogen is important because nitrogen is a gas which has one of the most important properties of nitrogen is it does not variate size with pressure. If I have nitrogen here at sea level, the gas is in one volume. If I take the same volume to the Everest Mountains, it will be the same volume. It does not expand or does not contract. That's why we have nitrogen in the airplane tires. We do not have oxygen, or we do not have compressed air, because otherwise the tires would explode whenever the plane went up or went down. So that allowed animals to conquer all the surfaces of the earth. Like we can have animals at sea level, we can have the condors, which are birds that fly at 4,000 meters high at the Andes region. We can have whales that dive deep up like 200 or 300 meters down in the ocean, and their heads, their ears, they do not explode because they have nitrogen. And the most important thing, the mastoid doesn't produce enough nitrogen to equalize the system. There's always a negative pressure. Why? For the tympanic membrane always to be very stretched, because otherwise the tympanic membrane would not convert and conduct the sound in a better way. So there's always a negative pressure. When the pressure is very low, it's very negative, there is a medialization of the malleus, and there is a signal to the tensor tympani tendon. This tensor tympani tendon is very close to the geniculate gangle, very, very close, like millimeters away. So it stimulates the geniculate gangle whenever it moves, and then the geniculate gangle stimulates the great petroso superficial nerves, the great petroso deep nerve, median nerve, and then we open our mouth. There's a signal for us to open our mouth. When we open our mouth, we do like this, we open the eustachian tube, and then the system equalizes the pressure. The same pressure of the middle ear is going to be the same pressure of the external, or the same pressure outside you are in. That's a very nice mechanism. But sometimes the eustachian tube doesn't work. And the eustachian tube is a very important part of this mechanism. Why? Because the middle ear and the mastoid in a normal condition must be sterile. They cannot have bacteria, virus, fungi. They cannot have anything. It's like the bladder. The bladder communicates itself with the outside, with the urethra, but the urethra is closed most of the times. It's a virtual cavity like the esophagus, because it acts like a physical barrier, an anatomical barrier for the bacteria do not go inside the bladder. The same thing happens with the eustachian tube. The nose, the rhinopharynx, is like the Disney world of the bacteria and the virus and fungal, whatever. And if the eustachian tube were open 24 hours a day, these bacteria would climb up the middle ear, and middle ear mastoid have very little defense against organisms. Because there's a very poor blood supply to it. So very little defense. That's why we see sometimes in diabetic patients necrosizing otitis externa or otitis media, because there's few vascularization, and when you have diabetes, the vascularization is even lower. So the eustachian tube is a physical barrier, closes, and whenever the pressure in the middle ear is too low, it opens. When it opens the eustachian tube, it equalizes the pressure. Some bacteria may go up, but the cartilaginous part of the eustachian tube have a lymphatic tissue that is specific to it, like they are called TODs, tube-associated lymphatic tissue, and they kill these bacteria. And this mechanism works for most of people, most of the times, in a very good way. But sometimes the eustachian tube doesn't work. Sometimes you may have like a very important otitis media, acute otitis media, and sometimes you may have reflux, or you have adenoid hypertrophy, or you have inferior turbinate hypertrophy, or you have deficiency of the muscles of the eustachian tube to open the eustachian tube, whatever. You can have blockages of this mechanism. This mechanism of equalizing the pressure cannot work very well. If this mechanism doesn't work, there will be always a negative pressure. Remember, on the mastoid, so the tympanic membrane, they have three possibilities. Either you can have atelectatic tympanic membrane, and we see this in patients with Down syndrome, for instance, that the eustachian tube doesn't work at all. So there's always an atelectatic tympanic membrane. But also we can see retractions at the most superior part, the most flaccid part of the tympanic membrane, which is the pars flaccida. And in these retractions, skin can go inside. This retraction can be not non-self-cleaning, because whenever you have a self-cleaning retraction is one thing. But if you have a non-self-cleaning retraction, you can have infections, you can have inflammatory process, you can have bone erosion, bone destruction, and then you have a retraction pocket cholesteatoma. Or you can have a perforation. A perforation, sometimes I say it's good. We do perforation sometimes in patients. When we do a tube, a ventilation tube, we deliberately perform a perforation in the patient's ear. What's the problem of a perforation? The perforation equalizes the pressure very well between the middle ear and the mastoid. But what's the problem of the perforation? It's a door open for contamination, because bacteria from the external respiratory canal can enter the perforation and then can colonize middle ear mastoid. And I told you middle ear and mastoid has very few defense. You can have biofilms on it, and then you can have a chronic suppurative otitis media. And this always bothers me, because when we talk about cholesteatoma and when we talk about granulation tissue and chronic suppurative otitis media, the first word that comes into our heads is mastoidectomy. But it's not a mastoid problem, it's a middle ear problem. It happens to be in the mastoid sometimes, but it's a middle ear problem. The birth of the problem is in the middle ear. That's why with endoscopes, we change a little bit the perspective. Instead of starting the procedure, whenever we have to do a procedure for cholesteatoma, for chronic suppurative otitis media, in the mastoid, we start the procedure where the disease starts. We start the procedure at the middle ear, clean the middle ear, clean the ventilation pathways that we have between the eustachian tube, middle ear, and mastoid antrum. And then if we need, we go to the mastoid. Doing this, we can sometimes preserve the mastoid air system. And if we preserve the mastoid air system, we can have a functioning mucosa, if the mucosa stays functioning, for the postoperative, for you, for the patient, to equalize the system in a better way instead of destroying the mastoid. Of course, this mechanism is not all 100%, because when you have a small mastoid, even if you preserve this small mastoid, uh, sometimes the mastoid does not function. The mucosa is not going to be function. And sometimes you have big mastoids and you destroy mastoids. In cochlear implantation, you destroy the big mastoid system. Most of the times the mastoid is normal, but the eustachian tube, if the eustachian tube works very well, there will be no problems. If the eustachian tube doesn't work, sometimes there will be problems when you destroy the mastoid on cochlear implantation. So that's a very interesting thing, talking about these ventilation pathways, these ventilation routes. And this is not a new thing. This is not a thing for endoscopic surgery. Dr. Tarano Pavo told about this like 20, 40 years ago, using microscopes. But the problem of using microscopes is to see what we call the tympanic diaphragm is very difficult. With endoscopes, we raise a tympanometer flap, we see. So, and we can see the blockages. We can see like granulation tissue blocking the tympanic isthmus. We can see cholesteatoma blocking. We can see a lot of things that under the microscope sometimes we cannot see in the middle ear. And then this can be very important and very useful. For instance, we see this retraction here. This is a self-cleaning retraction. As you can see, skin go in but go out. Probably there is a blockage here because the tympanic membrane is well ventilated. You can see there is air. There is a tympanosclerotic part here of the tympanic, but the eustachian tube probably is working. This patient probably had acute otitis media and a blockage here at the tympanic diaphragm, like with a web or a fibrotic tissue or a scar tissue after this acute infection. And the mastoid has a negative pressure. It's sucking down the tympanic membrane and destroy a little bit of this bone. This is very interesting, this retraction, to understand and to try to correct the retraction whenever we can or whenever we want. Self-cleaning retractions are like a kind of a gray area. Some people defend to attack this problem and to try to correct. Some people are trying to watch and scan and to see what happens in the future. But this is an example of a retraction. This is the same retraction. One important concept here is to understand the concept of the tympanic isthmus. I always say the tympanic isthmus is like the osteometal complex of the ear. Where is the tympanic isthmus? The tympanic, this is a left ear, by the way. This is the malleus, the incus, the stapes, anterior, posterior, superior, inferior. The tympanic isthmus is an anatomic landmark that is between the cochleariform process, which is here, and the incus joint. This is tympanic segment of facial nerve, lateral canal, long process of the incus, malleus. So this is the tympanic isthmus. The posterior isthmus comes from the facial recess to the incus joint, and the anterior isthmus goes to the Prusac space whenever we do not have a tensofold present, which is the minority of cases. 80% of us, we have tensofold. So the ventilation of the Prusac space is going to be a retrogradal ventilation through the tympanic isthmus, which is the most important ventilation pathway. And then if we have a blockage here in this region, we can have different types of communication, this ventilation syndrome, and then we can have retractions in this posterior part and the superior part, and then we always know the physiology of the things. This is a very nice image. I'm with the endoscope through the right maxillary sinus to the left ear. So the endoscope goes through the nose to the ear, passing to the eustachian tube. So this is the promontory, this is the stapes, this is the long process of the incus, this is cochleariform process, malleus, tympanic membrane. This is lateral, this is medial, superior, and inferior. This is the tensofold. As you can see, the tensofold here is blocking the anterior ventilation pathway. But the tympanic isthmus is this ventilation here. And as you can see, it's very small, very little. And if you have like edema of this mucosa, if you have a web here, scar tissue, it can close this tympanic isthmus. And if we close, we generate two spaces, a disventilation syndrome that can generate like perforations or retractions or atelectatic tympanic membrane, or the disease that we all know, the inflammatory conditions that we all know that we have in the middle ear and in the mastoid. So this is very interesting to understand these concepts of ventilation and these concepts of blockages of these ventilation pathways. So now we can see here this is a normal tympanic membrane here, but with a retraction, a very big retraction in the superior part, and probably there is a blockage here in this region of the tympanic isthmus. And probably the eustachian tube is working very well. The eustachian tube is here because this part of the tympanic membrane seems to be very well equalized. The pressure seems to be very well equalized, but we have a retraction in the most superior part here at this tympanic membrane. So we can see this, and also we can understand during the surgery that sometimes we can find those blockages in locus during the surgery. If we start the surgery with the middle ear where the surgery starts, we can see that sometimes, or most of the times, when you have inflammatory conditions, we have blockages. See, we had a blockage here at the tympanic isthmus, we had erosion here at the malleus, part of the malleus, and we had a blockage. We unleash this blockage, and then we always like to wash inside the mastoid. Sometimes you can wash with a saline solution, sometimes we can wash with antibiotic solution, and always try to see the eustachian tube region, the region of the eustachian tube, because seeing the region of the eustachian tube, sometimes it can be blocked. And if the region is blocked, no good for you. You can correct the tympanic isthmus, you can correct the ventilation pathways in the middle ear, but if the tympanic isthmus, the eustachian tube is closed, there will be no ventilation. So that's why we like to use also cartilage in order to fix these problems of perforations and these problems of retractions. First of all, because it's more easy to put one-handed, and in endoscopic ear surgery, we use just one hand. Second one is because it's a stiff tissue. It does not variate with pressure. So we can put the cartilage over there, and we do not worry a lot on the cartilage get sucked again by the negative pressure, but that sometimes can happen, especially during this period of post-operative, this immediate post-operative problem. And we can correct the problem closing and using less gel foam. Gel foam also provokes an inflammatory response in some scar tissue. And if we use a lot of gel foam to support a fascia, for instance, or to support a perichondrium, we may block with the scar tissue caused by the gel foam, we may block the ventilation pathways again. So we can have a very nice surgery and also have blockages. There was a recent meta-analysis published in Otology Neurotology talking about non-cholesteatomatous problems, chronic ears, and just suppurative chronic otitis media, comparing the results, just a tympanoplasty with the ventilation pathways open, and tympanoplasty associated with tympanomastoidectomy, with opening the mastoid and drilling the mastoid. Guess what? There's no difference. There is better hearing in the tympanoplasty only, and no difference between recurrence of disease when you preserve the mastoid. If you have granulation tissue only, if you don't have cholesteatoma, most of the times you don't need to open the mastoid. You don't have to open the mastoid. You can preserve the mastoid even with the granulation tissue. You can use medication, steroids in the postoperative, but you can preserve the mastoid air cell system, open the ventilation pathways. This is very important. If you do not open, no good. Open the ventilation pathways and correct the tympanic perforation. In this case, for instance, you have a very thin tympanic isthmus because the malleus is a little bit medialized. So you see the canal of the muscle, Jacobson nerve, eustachian tube region, protympanic space, protenucleus, carotid artery, supratubular recess. You can see also this retrotympanic area, the funiculus, the fustes, ponticulus, subiculum, sinus tympani, as you can see over there. The ponticulus is almost absent in this case, and then you can open the ventilation pathways using curved instruments. I always like to do a small curettage and open the posterior ventilation pathways and then wash inside. And when we wash inside, sometimes a lot of secretions, pus secretions or secretions from cholesterol granuloma or whatever, can come out of the mastoid when you open the isthmus, and you can wash the secretions and wash the mastoid and clean the mastoid. So this is very nice. But sometimes you do not have problems. You have perforations, but you do not have ventilation problems. The tympanic isthmus is open. Like in this case. In this case, we had a perforation. We elevated the tympanomeatal flap, but there was no problem of I would say, blockage of the tympanic isthmus. The tympanic isthmus was completely open, eustachian tube completely open. So in this case, for instance, a butterfly technique or a simple technique of tympanoplasty would work very well because there is no ventilation problems associated to this perforation. Whenever there is ventilation problems, granulation tissue, polyps, chronic supraortitis otitis medias, if you do just the cartilage or just the butterfly technique, probably this will not work. But if you open the tympanic isthmus, if you open the ventilation pathways, and if you correct the tympanic perforation using cartilage, preserving this ventilation pathways open, probably this will work in a very good way. So understanding the physiology is one important thing, but also understanding the anatomy. Even if you are not going to use the endoscope, if you understand the anatomy of the middle ear, which is the most fascinating anatomy, I think, in our area, I think you are good. You can understand this with also the microscope. So understanding the ponticulus, subiculum, funiculus. This is a left ear, by the way, anterior, posterior, superior, and inferior. I think you have a lecture on anatomy, so I will not talk about anatomy in a very close way. I will just show this slide because I think it's important. If you put the cochleariform process in the middle of the dissection, we can see also the differences at the mucosa. As the mucosa approaches to the eustachian tube, there will be a lot more lymphatic tissue and less respiratory mucosa. As we go towards the mastoid, we see less immunological tissue and a lot of respiratory mucosa. That's very important. We also see here the tympanic segment of facial nerve, first genu, second genu, mastoid segment, and also starting the surgery, especially when you have a cholesteatoma, for instance, starting the surgery at the middle ear, one of the first anatomical landmarks that you see whenever you elevate the tympanomeatal flap is facial nerve. So you see the facial nerve at the tympanic segment of the facial nerve, and also you can guess the trajectory of the facial nerve and understand in your mind, in your head, where's the mastoid segment of the facial nerve. And then if we need to do a combined approach, you know where the facial nerve is. When you start the surgery at a retroauricular space, you don't know where the facial nerve is. You guess. Sometimes you don't know. So that's why it's another thing that I always like to start the surgery at the middle ear, understanding the anatomy, understanding the position of the facial nerve. We can have a lot of landmarks. One nice landmark is this one. It's called malleus cap. The malleus cap is this cap here of this bone, and it's a very nice anatomical landmark because it gives you a dissection plane to dissect the tympanic membrane out of the malleus without leaving some tissues. And then you can have like a disease, like a cholesteatoma like this in the supratubal recess, eustachian tube is open, and then you can correct. If you do not elevate the tympanomeatal flap out of the malleus, it would be very, very difficult to see these lesions at the most anterior part, the supratympanic recess. If you think about cholesteatoma, the areas of the cholesteatoma that are more prone to recur are the sinus tympani facial recess, but also the supratubal recess. So to understand this is also very important to understand how to raise the tympanomeatal flap, raising, including the malleus. So there's still some disease over there. We can go with the suction, and then we can go with curved instruments to try to suck and to try to see. And then we can see if we already removed completely the cholesteatoma in the most supratubal recess area. And this is very important to understand. So exposure also of the middle ear is key. It's fundamental, very important. If you do not expose the middle ear, sometimes you can be lost during the surgery, and sometimes it's not good to use the endoscope because you need to expose things in order to work in a very good way. We can see here cholesteatoma, and the first thing we do is raise a tympanomeatal flap, expose the middle ear, see the limits of the cholesteatoma at the middle ear, sinus tympani region of the stapes, to see if we can dissect from the oval window niche. See, facial nerve over here, we can understand, see if the facial nerve is already with the dehiscence or not, and using curved instruments. I always say, if you want to start the surgery, endoscopic ear surgery, you can start endoscopic ear surgery right now with the instruments that you have already in the OR. But if you want to do cholesteatoma, you have to have instruments like this, suction, dissection instruments, curved instruments. It's like the same way of trying to do a frontal sinus surgery with a septoplasty tray. It's not good. So in order to do specialized work like the cholesteatoma, you must have some specialized instruments to see sinus tympani, to see hypotympanic cells, to clean the middle ear first. And then after you clean the middle ear, clean the oval window niche, clean the facial nerve, clean everything, after you go to the mastoid. Because after we clean this, we understand we can put angle endoscopes inside and see that's still cholesteatoma. So we clean here, but put angle endoscope and see inside. We already see the cholesteatoma here, the adus adentrum and antrum, and sometimes it's more easy to do a combined approach to remove this cholesteatoma. So we just have like 2 minutes, so I will pass in a more fast way. The same here, cleaning the oval window niche. The facial nerve in this case was dehiscent. We can clean here in a very close way, in a very good way, without disturbing the anatomical landmarks. And also we can clean facial nerve and clean everything, and then do a combined approach. This is a transmastoid approach. We can see the canal, lateral canal, and then we can have the middle ear and the mastoid opens here in a very good way, and then reconstructing at the end with the cartilage. And I do not reconstruct the hearing at the same time using PORPs or TOPs or whatever, because I always like to do a second look, and I always like to reconstruct at the second look in time. I talked a little bit about instruments, and curved instruments are very important if you want to do a surgery, a more advanced surgery. We can discuss the instruments later on. And I think that's it. The lecture was it to talk about these principles and the limitations, and to talk about the principles of endoscopic surgery. So thank you very much, Ricardo, for your time. We'll stop sharing here in a bit, and I hope you have enjoyed.
No, I enjoyed it so much. I always enjoyed your lectures, and I will probably ask you to do the one of cholesteatoma you offered me first time, so in another time. And as always, I learned a lot about you, a lot of your lectures, and thank you for everything, and thank you for being here, and thank you for teaching us all. I talk about the whole endoscopic ear surgery community. I think we all owe a lot to you, and I hope to see you in the near future, face to face. Thanks, Joao.
Thank you. Thank you.
See you. Bye. Thank you very much for everything.
Bye-bye.
Bye.
Thank you.